Bismillahirrahmanirrahim. My name is Professor Mazharul Hasan and I am the Professor of Ophthalmology, Dow International Medical College, Dow University of Health Sciences, Karachi. Today my topic of presentation is red eye. And you know this red eye is an emergency in ophthalmology, and today inshallah we will discuss you about etiology, treatment and diagnosis. Bismillahirrahmanirrahim. My name is Professor Dr. Mazharul Hasan. I am the in charge and chairman Department of Ophthalmology, Dow International Medical College, Dow University of Health Sciences, Karachi. Today my topic of discussion is assessment and management of acute red eye. As you all know, this is an emergency. If anyone came with the red eye in eye department, then it's an emergency and we must exclude the causes, and then according to that we treat. It is the most common complaint in eye OPD. A red eye can be alarming but mostly oftenly a sign of minor eye disease, but it could be a more serious problem than just a pink eye. As you know, the causes of the red eye is, one is traumatic eye, the another is non-traumatic eye. The causes of non-traumatic eye is usually can be a conjunctivitis, can be a subconjunctival hemorrhage, uveitis, orbital and periorbital cellulitis, keratitis, acute angle closure glaucoma, scleritis and episcleritis. Mainly patients come to us with the complaint of this red eye is the cause is conjunctivitis. Sometimes they are very worried when they have a blood in his subconjunctiva and they came in an emergency. The another cause of the red eye is traumatic, and the cause is obviously the cause is trauma. Corneal abrasion, corneal foreign body under eyelid, hyphema. Hyphema, you all know it's the blood in the anterior chamber. Because of the trauma, the blood came in the anterior chamber. The another is a chemical injury, corneal laceration and intraocular foreign body. When a patient comes to in our clinic with this complaint of either traumatic and non-traumatic, of course we should examine first, and according to that we prescribe we check his examine by torch, by the help of the slit lamp. We check the visual acuity, and then we see conjunctiva, we see cornea, we see any discharge like pus discharge, or we can ask about history about is the lid is sticking in the morning, and then we see is there any corneal defects, search for epithelial disruptions. And evaluation is very necessary, our history and examination. And when we do the visual acuity, of course we see the vision is normal or vision is decreased, because in some condition the vision is normal and in some condition the vision is decreased. Normally when a patient has a conjunctivitis, of course the vision is normal. When someone have a subconjunctival hemorrhage or periorbital cellulitis, the vision is normal. And if the vision is decreased, when we do the vision and the vision is decreased, it means the cause is trauma, keratitis, iritis, acute angle closure glaucoma and orbital cellulitis. It means visual acuity is very necessary prior to treat the patients. If you look this slide, this showing there in the conjunctiva there is a red color inferior temporal and nasal part. Usually when a patient come with this complaint, when we see and we tell him that it is a subconjunctival hemorrhage, and the cause can be a trauma, can be a cough and sneezing, sometime because of the hot season, sometime patient has a raised blood hypertension. And the good thing that it will be absorbed themselves, and it take around 10 to 15 days. And we usually we tell this thing to the patient that it won't hurt your vision, and it will be absorbed inshallah within 2 weeks. And you know, conjunctivitis is many type of conjunctivitis, like viral conjunctivitis, allergic, and viral conjunctivitis. And the most common is a bacterial conjunctivitis, in which what happening that the patient, when they come to us with the complaint of red eye, yellow discharge, then the one thing is very important, you can ask that is the lid is sticking. If they say yes, the lid is sticking, it means the conjunctivitis is caused by bacterial. If there is a viral, or of course if there is a viral, then we do stain, and by staining we understand that there are two main type of viral conjunctivitis. There's two type, I'm not saying that two type, the two way they present, like dendritic wake or amoebic wake. Then you can say yes, it's the viral conjunctivitis. And for allergy, yes, they give you a history of itching, foreign body, lacrimation, and when you examine you can see papillae and many other signs, and then you can label that it is allergic conjunctivitis. Yes, of course, if there is a bacterial conjunctivitis, we give antibiotic, and if it is allergy, yes, we give some steroid, and then we give some antihistamine, and for viral we give antiviral drugs. Look, this slide is showing that keratitis, mean inflammation of the part of the cornea, then can cause be infection, can be mechanical trauma, and sometimes chemical injury like alkali injuries, worse than acid. Bacterial keratitis. When a patient comes with this problem, when we examine, we see that the red eye, purulent discharge, corneal opacity sometime, and have decreased vision, and sometime reaction and hypopia. It's very difficult to treat bacterial keratitis, but we give some topical antibiotics which cover gram-positive and gram-negative bacteria. And prior to give this antibiotic, the best way to scrap and then culture and then stain, and then according to that we give antibiotics like fluoroquinolone, Bactrian, crefazine, amecine are indicated. And this slide, if you see that it is a viral keratitis, is mostly the herpes simplex and as well as the herpes zoster. And there is a if you see in the right side, there is a one slide is showing the dendritic pattern of keratitis, and then if you see the another picture which showing the at the scalp, is showing the herpes zoster ophthalmicus. Of course, when anyone have this viral, then we can give the antiviral therapy, as well as we give acyclovir ointment with we give painkiller and sometime we take opinion from the skin as well as. Uveitis is the inflammation of the iris, ciliary body and choroid, and we divide uveitis in anterior uveitis, intermediate and posterior uveitis. And it's alarming for anyone who have this problem, and when they come in our clinic, they complain of photophobia, red eye, decreased vision, pain, and there are many causes, and it's very difficult to diagnose why he has suffered this uveitis. And sometimes we write many investigation, and then we start treatment. And you see this is the sign of uveitis. In the one slide is showing the ciliary congestion, the another slide showing posterior sinica, and epithelial, and then in the lower side they're showing that KPs and hypopia in the another slide. As I told you that the uveitis is the inflammation of iris seedly body and choroid, and for that we give cycloplegic drug cyclopine to prevent the pain, or then we give as well as some steroid drops, as well as we give immunosuppressive medication. And the aim of this is to reduce the pain, and because these patients have developed glaucoma, cataract, and as well as macular edema. Acute angle closure glaucoma, it is an emergency in eye, and normally we don't have more emergency, but acute angle closure is an emergency in which what happened, that patient has their intraocular pressure is more than 45-50, when the normal, you people know that the normal intraocular pressure is 21 millimeter mercury, but because of the angle closure and people block, the pressure is raised up to 45-50, and patient has severe headache, pain, and when we examine that, they have a mid-dilated pupil, cloudy cornea, and a patient has facing nausea, vomiting. And if we will not treat, then chances of visual deterioration is more. For that we give some drugs in a week. Sometimes we admit patient and we give oral acetazolamide, and we give IV mannitol 250 as well as glycerin sometime, and then the pressure is decreased up to 30-35, then we can add the beta blocker pilocarpine. And when the patient is stable, then we see their angle, if the angle, and in some cases we do laser peripherectomy. And if you look, this slide is showing the pre-orbital cellulitis, and it's usually occur in children, and in which the vision is normal but extraocular mode normal, but it's showing a little bit swelling of the lid, tenderness, fever, and we give systemic antibiotics, and we admit the patient and we give systemic antibiotic, and patient will be cured with the time. Orbital cellulitis is an emergency. Again, it is an emergency, and it's a life-threatening. It's not only the vision threatening; it's also life-threatening condition. And when a patient come to us, of course they have a swelling on their lid, they have a proptosis, chemosis, and they cannot. It's very difficult to open their eyes, and the ocular movement is sometimes restricted. Patient has fever. And chances of it's also sometimes it's affect optic nerve, and for that, as I told you, that orbital cellulitis is an emergency. For that, we should admit this patient. We write some investigation like CT scan of the head, blood culture, and then we start same time antibiotics, systemic antibiotic, and sometimes we need surgical defibrillator. And if we will not treat on time, then there is chances of complication, and the complication can be meningitis, cavernous sinus thrombosis, and sometimes loss of the vision as well. Yes, episcleritis is also a red eye, and when anyone have examined, and then we see there is some redness as well as a localized nodule, or sometimes it's diffuse nodules, and other things are normal, then yes, if it is inflammation, we give treatment, like we give topical NSAID, topical steroid, and it will be better in couple of days. Scleritis is again, it is inflammation of the sclera, and it is a more destructive disorder, usually occurring at the age of 20 to 40, and it has a pain but less escapade to the episcleritis. And there are different type of scleritis, some are diffuse or nodular, and the treatment is treatment is, of course, we can give instead indomethacin painkiller, naproxen, as well as steroid and cyclophosphamide, azathioprine, and cyclosporine. And if you look, this slide is showing the foreign body on the cornea, and if the foreign body on the cornea, of course, patient have red eye, patient has irritation, they cannot close their eyes, and they come to us. And when we examine on slit lamp, yes, we can. And if you look in the another slide, they is showing the iron foreign body, and for that we put sometime local anesthetic drop, and then we take out the foreign body, and after that we give antibiotic drops. And this slide showing the chemical injury. It happened that someone have that chemical injury, and it is again emergency, and as soon as they come to us, before more asking the history, we start to treat the patient, and we irrigation with water, we start irrigation with water, and then treatment is depend upon the acid and alkali depend. And if you are not prompt treat, then it can lead to corneal opacification, melting, perforation, and severe glaucoma and late complications are. And if you this slide look that initially the patient come with the corneal abrasion, corneal sloughing, corneal cloudy, and then in the later stage they become opacification and their new vascularization. As I told you before that it is emergency and immediate irrigation necessary, and simultaneously we give antibiotic, we give some cycloplegic drugs, and then it's going better if they come on time. As you know that red eye is emergency, and it's not only a bacterial conjunctivitis. Sometimes we think that is a bacterial conjunctivitis and we give antibiotic, but as you see this in this lecture, that the causes are many, like uveitis, corneal ulcer, acute congestive glaucoma, and foreign body. For that, if anyone have a red eye, they must come to eye specialist, and they examine timely, promptly, diagnose promptly, and then they start treatment. And sometime we save the eye as well. As if you will not come to us and you think that it is only a conjunctivitis and you treat by themselves, then chances sometime they lost their eyes. For that I tell to everyone that if anyone have a red eye, you must visit to eye specialist. And when you come, of course, timely come, accurate diagnosis, appropriate referral when indicated, knowledge of each entities, make correct diagnosis, and treatment is likely. Thank you very much for giving your time. हो गया 20 मिनट का मेरे ख्याल में।